colleagues.
на
I
очередном
am
Tumor
glad
Board,
to welcome you to
посвященном
our tumor board
лечению герминогенных опухолей яичек,
devoted
распространенных
to
форм
treatment of
герминогенных опухолей яичек.
NSGCT,
Я напоминаю вам, что наши тумор-борды проводятся
non-seminomatous
Российским обществом
germ cell
онкоурологов
tumor of the
и
testis.
своей целью
This tumor
преследуют
board
исключительно
is organized by the
повышение
Russian
уровня
Association of
образования
Oncological
наших
Urology.
специалистов. Мы
The
всех
goal
призываем
is to improve
врачей из
the
любых
education of
лечебных
our
учреждений
specialists.
регионов
We invite
присоединяться к нашим
doctors
тумор-бордам, присылать
from
интересные
different
клинические
regions of
случаи,
Russia join
выступать
in
с
our tumor board,
презентациями.
send interesting
Мы
clinical
регулярно
cases,
приглашаем
make
ведущих экспертов
presentations.
в
We
этой
also invite the
области
leading
из
experts
разных
in this
городов, из
field
разных
from
стран.
different
И сегодня
cities of Russia
в
and from
разборе двух
different
клинических
countries.
случаев
And today we'll
участвуют
be
ведущие
discussing two
специалисты в области
clinical
лечения
cases.
герминогенных
We
опухолей
have three
яичка.
major
Это
specialists in the
наш
field of
гость, наш большой друг,
NSGCT. That's our
профессор
guest.
Аксель
And a big
Хайденрайх,
friend of
профессор
ours,
и директор
Professor
урологической
Axel
клиники
Heidenreich,
Кёльнского
a
университета,
professor
человек,
at
имя
the
которого знает весь
Clinic of
урологический
Cologne
мир.
University,
Аксель, мы
whose
вас
name is
приветствуем.
known to all urologists.
Профессор Борис
Axel,
Яковлевич
welcome to
Алексеев,
the tumor board. Also, we have
замдиректора по
Professor
науке
Boris
Института
Alexeyev, who is the
Герцена,
Deputy
Михаил
Director
Юрьевич
on
Федянин, наш
scientific
ведущий
issues of the
химиотерапевт,
Herzen
специалист в
Institute,
области лечения
Mikhail
герминогенных опухолей
Fedyanin,
яичка,
a medical
Мария
oncologist, a
Игоревна Волкова,
specialist in the
профессор,
treatment of
э,
NSGCT,
моя
Maria
коллега
Volkova, a
уже многие
professor
годы, которая
and a
тоже
colleague
имеет
of
огромный
mine.
опыт как
She
хирургии, так и
has
лекарственного
had a lot of
лечения
experience
опухолей
in
яичка,
the
и
field
наши
of
докладчики,
surgery
наши
and the treatment of
аспиранты Алексей Матвеев
NSGCT,
и
and our residents, Alexei Matveev
Георг
and
Аркелян.
Georg
Мы
Arakelian,
будем
who will
сегодня
be
рассматривать
our
два случая. Я
speakers
хочу
today.
сразу
We'll
предупредить,
present
что
two
эти пациенты
cases,
прошли
and I'd
долгий
like
путь.
to
Они лечились
warn
в
you,
разных
these
лечебных
patients
учреждениях,
have been treated in
где, на мой
different
взгляд,
clinics,
не
in
совсем
different
правильные лечебные
healthcare
подходы
facilities,
применялись
where, in my view, not the
на разных
optimal
этапах их
treatment was
лечения.
provided
Поэтому
at the different
очень важно
stages of
сегодня
therapy. So
обсудить,
it is
насколько
important
правильно
today to
получали
discuss
лечение эти больные.
the treatment
Герминогенные опухоли
those
яичка хоть и
patients got,
составляют небольшой
and
процент среди онкологических заболеваний, но
NSGCT
являются основной причиной
is not the
смертности
largest
среди молодых
percent
людей
among all cancers, but
этой
one of the
возрастной
major
группы от
reasons
онкологических заболеваний.
from cancer among people of this age. And the price of a mistake is very high because most of the patients can be fully treated if the treatment is correct. That is why today's tumor board is very important in terms of the correct approach to therapy, the timeliness of the therapy. And let us start with our first clinical cases. Alexei Matveev will be our speaker. Please, the floor is yours. Well, good afternoon, good evening, distinguished colleagues. I'd like to present the first case. That's the patient, 24 years old, from Volgograd. Unfortunately, we do not see your slides. Could you share your screen with us? I am sorry, just a minute. All right, here we go. Now you should see the screen. Again, a 24-year-old male patient who was hospitalized to the Volgograd Central Clinical Hospital with complaints of right testicle enlargement, uneventful medical history. You can see preoperative tumor markers, AFP 1500 international units per milliliter, HCG and LDH within the normal limits. On September 11th, right orchiectomy performed. According to CT data, there were metastases in retroperitoneal lymph nodes. Histological examination, mixed germ cell tumor containing components of immature teratoma and embryonal carcinoma, 1 month Later, the level of AFP was 700 international units per milliliter. The patient received no systemic anti-cancer treatment, and unfortunately, starting from October 2017 to February 2019, the patient was lost to follow-up. In 2019, there was a progression of disease. Well, you can see enlarged retroperitoneal lymph nodes, tumor mass 10 by 16 by 16 centimeters. The patient received 2 cycles of BEP chemotherapy, but unfortunately, the effect was not assessed. In May 2019, according to CT scan, after 2 cycles of BEP, the tumor mass was 225 by 100 by 242 millimeters. You can see AFC 67 international units per milliliter, HCG 1.2, LDH 243 units per liter. The patient was sent to St. Petersburg, where he got a 3rd cycle of BEP chemotherapy. Adverse events included nausea grade 2, vomiting grade 1, and neutropenia grade 4. As a result of it, there was a 4th cycle of BEP postponed. At the beginning of June 2019, there was a decrease of AFP to 44, and a decision was taken to use TIP chemotherapy. The patient received 2 cycles. The last one was in July 2019. The residual tumor size regressed. Well, you can see 221 by 106 by 226 millimeters. Not a very significant decrease. The markers level was AFP 38.7 international units per milliliter. HCG was within the normal range. Here you can see the assessment of the effect. AFP was the lowest. In July 2019, it was 25 international units per milliliter. A month later, there was a rise of AFP to 30, and in September to 40 international units per milliliter. The patient was denied a surgical excision of the residual tumor. As for the general condition of the patient, there was a progressive deterioration of patient's condition. There was a weight loss. The patient had anorexia. At the end of September of 2019, the tumor mass was 244 by 122 by 243 millimeters in the abdomen, with aortocaval region involvement and displacement of the adjacent structures. At the end of November 2019, the patient underwent retroperitoneal lymph node dissection, resection of mesocolon and the greater mentum at the Blokhin Cancer Research Center. You can see the picture, operative field after laparotomy on the left. The tumor mass was the greater mentum, as well as the mesocolon and the descending colon. The blood loss was 1400 milliliters. There were no perioperative complications. You can also see the removed tumor on the right of the slide. According to histological examination, this metastatic tumor contains components of mature teratoma, hyaline cartilage, acidic cavities lined with the cylindrical epithelium, stratified squamous epithelium filled with mucus and keratin debris, signs of great therapeutic parthomorphosis, grade 4, no embryonic component was detected. After RP-LND at the end of November and December 2019, AFP was 1.39 international units per milliliter. HCG and LDH within the normal range, according to CT scan of the abdomen at the end of January 2020. There was no evidence of cancer recurrence in the abdomen, retroperitoneum, and the lungs. 15 months after RP-LND, there was no evidence of recurrence. All tumor markers are within the normal range. Okay, may I go to questions? Yes, go ahead. Go ahead with the questions. All right. Okay, here are the questions. Well, you can see that in this case, the result was not quite bad at the end of the treatment, but as we look at the history of this patient, I've got several questions, and I'd like our experts to answer them. The first question is, did the patient require a second-line chemotherapy after 3 courses of BEP, or should the patient be sent to RP-LND right away? The second question, is it reasonable to avoid surgery in patients with elevated levels of tumor markers? You can see AFP was a bit elevated, then there was a plateau, and there was just an elevated AFP in recent months. And the third main question, are there any contraindications to RP-LND in patients with normalized or plateaued tumor markers? And if there are such contraindications, what are they? So let us start with our German guest, Professor Heidenreich. Axel, what's your take on that?
So first, if I go back to your first question, definitely the patient would not have needed a second-line chemotherapy, because if you consider his very first CT scan, you already identify that this must be mature teratoma in the retroperitoneum. You have a lot of solid lesions, you have a lot of cystic lesions, so he had a good prognosis after orchiectomy with his slightly elevated AFP levels. And then after 3 cycles of PEB, his marker levels, AFP levels plateaued. But on the CT scan, he had these typical signs of teratoma. So in this situation, this patient should have undergone surgery immediately. And there was no need for any type of second-line chemotherapy. So what we usually do if you have this type of a good prognosis patient, we just deliver 3 cycles of PEB without any imaging control within the cycles. We only would perform an additional CT scan after cycle 2 if the patient would develop some symptoms due to maybe progressing teratoma, like a growing teratoma syndrome. But typically, you perform 3 cycles or 4 cycles of PEB. You don't need necessarily an imaging study in between the cycles, except, as I told you, except for newly developing symptoms or rising markers. And then in this situation, patient should have undergone immediate RP-LND. The avoidance of surgery in this patient with slightly elevated AFP levels is not reasonable, because also if you consider the CT scan, you see a lot of cystic lesions. And if you would do a biopsy of those lesions, and if you would measure AFP levels in the cystic fluid, you always will find significantly elevated AFP levels, or in some cases, beta HCG levels. And so these slightly plateauing markers are just the result of a reabsorption of AFP due to the cystic wall and then entering the systemic circulation. So plateauing markers are not a contraindication for RP-LND. And so to sum up this case, he should have had surgery immediately after 3 cycles of PEB.
Thank you very much, Axel.
Boris, what is your take on that? Thank you, Vsevolod. Well, as for this patient, he is a very complex patient because he was treated wrongly right from the start, because when there was the manifestation of the disease and metastasis, chemotherapy wasn't given to this patient for 1.5 years. Is my understanding correct? Yes, exactly. And also, when we have such patients, it's difficult to understand whether this first cycle of chemotherapy was quite adequate, whether the dosage was adequate, whether the adherence process was adequate. So there are always complications like this. I agree with Axel. As for this patient, we should have sent this patient to RPL and D right away. But when we do not have information about the quality of this first line chemotherapy cycle, whether it was adequate or not, and when tumor markers are elevated, we usually do the second line of therapy, and after the second line of therapy, we send the patient to surgery. In this case, we didn't have enough information. If the chemotherapy was adequate and we monitor the patient on our own when we have plateaued the tumor markers, well, in this case, of course, we send the patient to surgery right away. But in this case, I would probably send him to a second line therapy because we didn't have enough information about the adequate treatment in the past. Well, as for is it reasonable to avoid surgery in patients with elevated levels of tumor markers? Well, that's a good example showing, and Axel was absolutely right. Well, markers can be elevated in patients with growing teratoma, and that is why if we just avoid the surgery, in this case, the patient can die rather fast. I think that's the wrong approach. As for contraindications to RPL and D, I think, well, maybe some kind of dissemination into bones, into liver. Only in this case, well, there might be contraindications to RP, LND. Okay, Mikhail, what about your view as a medical oncologist? Well, usually we give 3 cycles of BEP, but the tumor was quite large, and we can see that the tumor markers were within the normal range. Well, we knew it was mostly a teratoma that this patient had, and so you can see even when we had the growing nodes, well, that was an indication for RPL and D. Well, as for whether the second line treatment should be administered when we just focus on tumor markers, we can look at the Fizazi group, and they try to measure tumor markers when they dropped after the first cycle. There are also such protocols used in our clinic in order, for example, after BEP to switch over to, for example, TIP, but we did not see any significant effect from this switch. But here the situation is different. The patient couldn't fall into this protocol. The teratoma worsened his quality of life, so surgery was totally justified. Well, I would not administer a second-line TIP chemotherapy. I would send him to surgery, and only after this, depending on the situation, chemotherapy could be administered. Well, as for the elevated tumor markers, I should say that sometimes we have patients with poor prognosis, with very high level of tumor markers, and sometimes we do not manage to normalize the situation with the level of tumor markers when the therapy is over. So we can have patients who have elevated tumor markers, but we send the patients to surgery, and there is therapeutic pathomorphosis after this. So I should say RPL and D plays an important role here. Well, unless there are some things that cannot be excised or removed, only in this case, well, if the tumor is large, well, the tumor will worsen the condition of the patient, but I would send the patient to even palliative surgery if the tumor was large. Thank you, Mikhail. Maria, you as a wonderful surgeon, when you look at this picture, can we see the patient's pictures, by the way? What is your impression? And again, as you can see, the patient was treated in St. Petersburg. Well, this particular mass cannot be removed and the patient should not be operated on. That's what they told this patient in St. Petersburg. Well, of course, any surgeon understands that this surgery can be risky, but in tertiary centers, specialized centers, well, we can achieve quite good results if we assess the situation correctly. Well, I can say, in fact, that despite this picture, Axel will probably support me. In my view, we should not just make a decision on the basis of X-ray pictures or CT pictures, because the complexity of the procedure does not always correlate with the computer tomography pictures. This surgery was quite simple. It lasted just for 1 hour without any blood loss, mostly, and I think all experts were absolutely right who voted for retroperitoneal lymph node dissection without the second line of therapy. But unfortunately, often our patients not just undertreated, but also overtreated. And usually when there is a residual mass, the mass is not removed. And unfortunately, for such patients, it is tantamount to death. That is why they should be treated actively. Axel, in your view, concerning this X-ray picture, does it correspond to the complexity or the simplicity of the surgery? Because it was simple, a simple surgery. If you look at this X-ray picture, what would you think? What can you expect in the operating room?
Yes, I would completely agree with Maria. So although there is a very large residual mass, it did not change significantly between the CT scan prior to chemotherapy and after chemotherapy. And considering that the majority of this residual mass contained mature teratoma, you would not expect a significant desmoplastic reaction induced by chemotherapy. So most of those patients who have these large teratomatous lesions can undergo surgery with a quite, let's say, simple process. You still need to secure all the major vessels to be, just in case you would injure them, that you can control it. But most of the patients with these teratomas are quite easy to resect. It is more difficult to resect a small residual mass of maybe like 2, 3, or 4 centimeters in diameter if the primary mass was like 10, 12, 15 centimeter and it shrunk down to the small residual mass after chemotherapy. Because in this situation, you would expect a lot of desmoplastic reactions, and then it is much more difficult to dissect a proper plane between the major vascular structure and the residual mass. So it is always important to compare the CT images, and in some cases where you expect, for example, infiltration of the aortic wall, also to perform an MRI of the small pelvis. But it is always very, very important to compare the CT scan prior to chemotherapy and the CT scan after completion of chemotherapy, and it will tell you a lot about the complexity or the simplicity of your surgery.
Thank you very much, Axel.
I think we can move on to our second case devoted to this problem as well. So I will ask Georg to demonstrate the second clinical case. Please. Good evening, dear experts. Allow me to share my screen with you. Here is a clinical case number 2. A patient is 29 years old And on September 1st, 2015, in Nizhny Novgorod, he had right orchiectomy because of the enlargement of the right testicle and the increase of tumor markers such as AFP 38.4 and HCG 84.4. Well, histological examination showed that the patient had the germ cell tumor, the typical seminoma, embryonal cancer, and rare areas of yolk sac tumor with syncytial trophoblast cells. No concomitant diseases, but there were metastases in the retroperitoneal lymph nodes. The patient received 3 cycles of BP chemotherapy. There was a positive dynamic in the form of the reduction of the size of retroperitoneal lymph nodes by 20%, a stable disease in the mediastinal and supraclavicular lymph nodes. The tumor markers were normal. In November 2015, thoracoscopy and posterior mediastinal lymph node biopsy, histological examination, grade 4 therapeutic pathomorphosis. The patient was followed up until September 2018, no signs of disease progression. However, in October 2018, there was a progression of disease, and there was an increase in the size of mediastinal lymph nodes up to 12 centimeters and an increase in the size of retroperitoneal lymph nodes to 11.7 centimeters. The tumor markers were within the normal range. Specific therapy was not administered. The patient was dynamically monitored. In March 2019, there was an increase in the size of the retroperitoneal lymph nodes up to 20 centimeters. Also, there was elevated tumor markers such as AFP to 6.29 units per milliliter. The patient was recommended a second-line chemotherapy, TIP, and in April 2019 to August 2019, the patient got 4 cycles of TIP. No adverse events were noticed, but the CT scan showed an increase in the retroperitoneal mass up to 23 centimeters. Due to this, on November 25th, 2019, the patient got the PRLND, and there was the retroperitoneal residual tumor, 25 by 20 centimeters in the aortocaval space, up to the bifurcation of the iliac arteries. And this residual tumor included the left and right arteries and veins, the aorta, as well as the abdominal aorta. The vena cava, the inferior vena cava, was shifted to the right, and there was the growth into the aorta up to 4 centimeters. The patient had the circumferential resection with grafting done. Gore-Tex 16 was used, and you can see the clasps used at 29 minutes. Histological examination demonstrated metastasis of the germ cell tumor with signs of grade 3 therapeutic pathomorphosis, and in the conglomerate cells there were mature teratoma cells. On January 30th, 2020, the patient at the Blochin Research Center had right thoracotomy and mediastinal lymphadenectomy, and there was the full therapeutic pathomorphosis, and the patient was sent for dynamic monitoring. In March 2020, the follow-up examination revealed a recurrent tumor, 12 by 21 centimeters in the abdomen. The tumor markers were normal. On April 29th, 2020, repeat laparotomy with removal of the recurrent tumor. Histological examination showed mixed germ cell tumor containing components of embryonal carcinoma and yolk sac tumor. the patient was recommended the dynamic monitoring. However, in August 2020, a second recurrence occurred 6.7 by 5.7 centimeters under the anterior abnormal wall. The tumor markers were normal. Starting from October 29th, 2020 to February 2021, the patient received a third-line TGO chemotherapy, 5 cycles. The patient will have the 6th cycle soon. The maximum effect was stabilization of tumor markers, and right now tumor markers are within the normal range. Thank you very much. That was my case. Thank you, Gevorg. This case even more complex, more complicated, and I would like Axel Heidenreich to comment on this case. What do you think if the treatment was correct at different stages? Axel, what's your view?
So, I mean, I guess if we just consider this case from the beginning, the delivery of chemotherapy was completely okay. So when he presented after orchiectomy, he had, according to his tumor levels, he had a good prognosis. So 3 cycles of PEB was completely okay and within the guidelines. And what I was a little bit surprised of is that you reported that the retroperitoneal lymph nodes decreased in size by about 20%, but they still were visible. So usually this is a patient who should undergo post-chemotherapy RPL&D. And then, depending on the histology of the retroperitoneal lymph nodes, you decide what kind of, how you treat the remaining metastatic deposits. Now, in his case, he had mediastinal lymph nodes, and he also had the supraclavicular lymph nodes. Usually, those lymph nodes also need to be resected in a second procedure. So I would have taken this patient to the operating room a little bit earlier than it was definitely done. Then if you consider just the clinical course of the patient, he had at least a documented disease progression about 3 years after the thoracotomy. So this is a typical case of late relapse. And when you have patients with late relapse following primary chemotherapy, you always have to think about chemorefractory disease. So the first decision you have to make is if the patient needs to undergo surgery or if there is any benefit of some type of salvage chemotherapy. Now, in this case, I also would have gone for surgery at first time because he did not have significantly elevated markers. So most probably the majority of these residual elements would be either teratoma or just chemorefractory disease. Could also be malignant somatic transformation. So then I would have started with the RPL&D as you have done. And depending on the infiltration of adjacent structures like the inferior vena cava, the abdominal aorta, or even small bowel or whatever, you have to resect everything which is infiltrated by the tumor, at least to increase the cure rate. So performing this type of extensive retroperitoneal RPL&D followed by typically complete resection of the extra retroperitoneal masses would be within the guidelines. And just looking at the histology of resected masses, there would have been no really a good reason for adjuvant chemotherapy. We don't have any prospective randomized trials, but at least we know from this old French studies that adjuvant chemotherapy has some benefit in patients who have more than 10% of viable carcinoma, but the benefit is only in the reduction of the progression-free survival. There is no benefit in terms of overall survival. Now, considering that this case had chemorefractory disease because of late relapse, I also would not have done any type of adjuvant chemotherapy. And now with this relapsing marking negative tumors, they just demonstrate to you that this is chemorefractory disease, and most probably this third-line chemotherapy you delivered now is just some type of, let's say, desperation treatment because we cannot perform like one surgery after the other because there is still a risk of residual disease being in place after third-line, fourth-line surgery. So what we would consider in this situation to get some biopsies of this remaining residual masses and to do a molecular analysis. So we usually run a next generation sequencing in these patients, considering about a little bit more than 200 druggable mutations. And then if you are lucky, you can identify one of those druggable mutations. And we have
конкретные мутации, и таким образом, которых мы наблюдаем, у которых есть мутация определенных генов.
And they are at least under control for about 15 months, although they had undergone first line, second line, and high dose chemotherapy. And we had one patient who had significant mismatch repair deficiencies, and we started him on pembrolizumab, and it also resulted now in an ongoing regression of 15 months. So this could be another option in your patient.
Спасибо большое, Аксель.
Thank you, Axel. Mikhail, a question for you. Mikhail, a question for you. Let's start with adjuvant chemotherapy after RP-LND. Well, you remember the histological examination. There was the therapeutic pathomorphosis, grade 3, not grade 4. What is your view? Should adjuvant chemotherapy be administered or not? Everything depends on the staging. Well, up to some time at our center, we had the complete pathomorphosis of the malignant tumor plus teratoma. But when the criteria for assessment changed, it turned that pathomorphosis grade 3, that means mature teratoma or immature teratoma. So it's hard for me to say whether this therapeutic pathomorphosis grade 3 with the teratomic component as our pathomorphologists stage or not, or maybe this is the malignant component. If it's a malignant component, if it's more than 10%, in this case, well, we administer TIP after BEP. But again, as for the tolerance of TIP, when first it's a BEP, then RP-LND, then TIP, the tolerance is very poor. 75–80% of patients after 2 cycles are not ready to tolerate this chemotherapy, and we often cannot complete the treatment. But, we won't have an impact on overall survival in this case. And the second question. Well, as for TGO, I met this patient in August last year when he had a quick progression, when there was the growth of the malignant component. Well, you can see the ultrasound data in August. The treatment was in the retroperitoneum, but there was a good response to TGO. The mass was reduced from 18 to 7 centimeters. Now it's the last cycle, and then we'll ask the surgeons to remove the residual mass. We know that we have some effect, and there might be the malignant component, surgery can be quite efficient after the 4th and the 5th cycle. So this is an isolated response. There is nothing in the subclavicular space, only in the retroperitoneal space. And in this case, after TGO, we sent this patient for surgery. As for the autoimmune therapy concerning the treatment of NSGCT, the efficacy of this therapy is very low. If there is a response, it's a very short one. Well, this therapy does not work as far as NSGCT is concerned. Well, as for whole genome sequencing, again, such germ cell tumors are different from solid tumors. And of course, there is resistance to chemotherapy, and these cases are non-druggable. So that is why in this case, well, maybe you have some effect, but, well, do not put your hopes on it. Even if there is such an effect, if you have access to such drugs, and we have problems with access to such drugs, and we do not have protocols allowing patients to select patients to test for mutations, the efficacy of treatment is very low. If you look at major studies, well, it's 10-14%. For germ cell tumors, well, if there is a response, it's usually a short one. And of course, we can administer a target drug if there is one. But again, well, as for the effects, they do not last long, unfortunately. Well, please, technical service, switch off your microphones because you interfere. Okay, anyway, after the removal of the residual tumor, well, the histological examination showed that there is a live tumor. And, well, technical service, please switch off the microphone because you interfere. Okay, Mikhail, after the removal of the residual or recurrent tumor, should adjuvant chemotherapy be administered? Well, that's a late recurrent. We know that they are refractory to chemotherapy. No, I mean the recurrence that occurred in our situation. Well, we know that late recurrences are chemotherapy refractory. There might be a malignant component. When the doctor looked at histological examination, he understood that the surgery should be radical, and that's a late recurrence, and well, there would be a poor response to chemotherapy because the patient had already BEP, so maybe in this case we would listen to the opinion of the surgeon. If the surgeon says, yes, we removed everything, that's a salvage surgery, classical salvage surgery. In this case, we could just monitor the patient. I agree that in this clinical situation, administering TGO or DMOX as adjuvant therapy after RPLND would probably not give any benefits. We don't have enough data on that. May I interfere? May I interfere? It's Maria. Well, as for this clinical situation, I should say that taking into account the late recurrence, the toxicity of the first and second line of therapies, as well as, well, we have some echo online. Technical service, please switch off your mics. A decision was taken to follow up the patient only, dynamic monitoring, on the basis of those issues mentioned by Mikhail Yurovich. Boris, do you agree with that? Just follow up. With whom? Do you agree with whom? With Lenin or with Karl Marx? It's a joke. Well, I agree with Mikhail Yurovich, with Mr. Fedyanin. As for adjuvant chemotherapy, this patient had already gotten 2 lines of chemotherapy, and as far as I know, after 2 RPLND, well, the first one was retroperitoneal, the second one was mediastinal. That was R2 resection, right? No, that was a radical. It was a radical procedure, according to the surgeon. Okay, so adjuvant therapy wasn't administered, and that was right. I think that after the 6th cycle of TGO, well, what else can we offer to this patient? I agree that we can do a whole genome sequencing, but I've never recalled the situations when a target drug could be administered after this. I think surgery is the only option here. Thank you. Thank you, Boris. Axel, after the removal of retroperitoneal residual tumor, how often should the patient be examined? What should be the follow-up as far as such patients are concerned? How often?
In this situation, we would go for about follow-up every 3 months for a total of 2 years. Because if you consider the frequency of relapses, about 90% of those patients will relapse within 2 years. So if they are relapse-free, then after 2 years you can extend the follow-up procedures, but very extensive during the first 2 years of therapy.
Можно сказать, очень хорошее. Итак, раз в 3 месяца обследование в течение 2 лет.
I don't understand.
Thank you very much, Axel. Unfortunately, your voice was like from the space, but I think we got the message.
Словно из космоса. Мы получили ваше сообщение. Colleagues, well, once again, I'd like to say that despite the fact that this pathology is relatively rare, the right approach to treatment will determine the success of the procedure, and all the subtleties of treating NSGCT is known only to those people who treat the people with NSGCT on a regular basis. I urge you to refer such patients to large centers who deal with the treatment of NSGCT patients. If you have any comments, any ideas concerning these 2 cases, or comments in general regarding the treatment of such patients, you are welcome to do it now. Maria, Boris, Axel. Yes, may I start? Well, I'd like to make a preview of the next tumor board, and I think that's an interesting observation. In 1998, I operated on a young man. At that time, he was less than 30, 25 years old, I guess, and he had an SGCT with lymph nodes metastasis. I was young, I was very aggressive, but at that time I was not ready for aortic grafting. At that time I wasn't ready, and there was a small part of tumor on the aorta, and when histology was done, it was parthomorphosis, grade 4. We followed up the patient thoroughly. After some time, he dropped out. I think he's just 1 year younger than I am. He's around 50 right now, must be right around 50. So 22 years have passed, even 23 years have passed since then, and he had a hemorrhagic stroke, and only due to this stroke he was examined, and he had the retroperitoneal tumor diagnosed, a recurrence. So biopsy confirmed it was a recurrence of the retroperitoneal tumor. It was a live tumor, and neurologists does not allow us to operate on this man as of now, because he has a hematoma, and he doesn't have a manifested neurological symptoms, but nevertheless, well, neurologists don't allow to operate. Should he be sent for chemotherapy or not? We did not start chemotherapy. That was our decision. We still wait for an okay for surgery. I do not know if my colleagues will agree with me or not. And why did I recall this case? Because next month they told us we would be able to operate on this guy, and we can present this case at the next tumor board. Well, we'll be waiting for that. What about markers, tumor markers? Tumor markers are all within the normal range. So if it's a late recurrence, you should operate on the patient. What about the histological examination results? Well, Mikhail, there were immature teratoma elements with well, there might be transformation in this case, and of course, chemotherapy should not be administered, at least now. We did not administer chemotherapy. Just wait till they allow you to do a surgery. So if you give me the floor at the next tumor board, I'll present this case. May I ask you a question? We were talking about NSGCT. I'd like to ask Axel a question. What is your position regarding indications for RPLND when there is a recurrence of NSGCT?
So if you mean if there is an infield relapse or just a retroperitoneal relapse of the disease after primary RPLND or post-chemo RPLND?
После непосредственно химиотерапии, вы это имеете в виду? I mean, residual seminoma after chemotherapy.
Seminoma. Okay, in seminomas. So what we usually do is we just look at the size of the mass. If there is, for example, residual mass of less than 3 centimeters, you just can follow it. We just can consider all these old studies where patients have undergone RPLND for these residual masses, and usually 0% of those patients had viable cancer. If the mass is larger than about 3 centimeters in diameter, we usually perform an FDG PET CT scan, and which is done about 8 to 10 weeks after completion of chemotherapy, to avoid false positive results due to resorptive inflammation. And if there is significant FDG activity in the residual mass, we usually get a biopsy to really prove that this is viable seminoma. And if this is viable seminoma, then we usually go for surgery and we remove it. We see these viable seminomas in about 15% of all seminomatous germ cell tumors who have been treated with chemotherapy. Surgery is not as difficult as it is said in the literature, so we did compare our RPLNDs for residual seminoma with RPLNDs for residual non-seminomas, and we did not see any difference with regard to surgery-related complications, with regard to the necessity of a resection of adjacent organs. We would not consider chemotherapy, radiation therapy, which would be another option in viable seminomas, because then you have to radiate a large the risk of secondary malignancies. So to sum up, residual lesions larger than 3 centimeters, significant FDG uptake about 8 to 10 weeks after completion of chemotherapy would be an indication for surgery in our hands.
Спасибо. Thank you very much, Axel. And if the tumor is 3.5 centimeters in the largest diameter?
Well, then we have just let's say you somehow have to make a rule and then you have to stick to the, so we just use this type of 3 centimeter margin. And whenever it is, whenever there is a mass about 3 centimeters, we perform the FDG PET and then we see if it's positive or negative. So this is basically the rule. There might be very, very, very few exceptions, but this is the general rule at our institution.
I think that's an international standard, and we also try to follow these standards, although sometimes this PET not always give us the optimal results, as our colleagues, medical oncologists say, but nevertheless, we follow these recommendations. Dear colleagues, I would like to thank all the experts who participated in our tumor board. I'd like you to remind that we are recording every tumor board, so you can watch it on our website of the Russian Association of Oncological Urology, because Axel, in the far east of Russia, it's already night. So our colleagues from Vladivostok will be able to watch the recording of this tumor board. And I hope that Axel and his colleagues will support our tumor boards online, but I hope that soon we'll be able to meet offline, face-to-face, in Moscow, in Cologne, and somewhere else. Mikhail, thank you as well for your expert assessment of clinical cases. Maria, thank you very much. Boris, thank you as well. And I would like to wish you a good evening and see you next time at the next tumor board. And Boris, you'll present your clinical case that you mentioned. Thank you, colleagues, and goodbye. Goodbye.
Okay, goodbye. Bye-bye. See you. Bye.